Our group looked at pandemic preparedness, plans and alternatives. And our fundamental conclusion was that governments need to act before there is a health crisis and not during and after it. By acting before and building capacity in low middle income countries as well in higher income countries, those capacities can be expanded at a time of crisis rather than being shut down with the devastating consequences that we saw. And during the conference we had several examples which helped us to develop that idea. In the case of healthcare, we were very lucky to have Colleen Littlejohn from Nicaragua, who described the Nicaraguan healthcare system and the way it had built for 17 years to build capacity, build hospitals, build an infrastructure of health brigades, which meant that when COVID arrived, there was a sufficient capacity within the healthcare system of Nicaragua not to close that system down. And what, of course, this brought in mind was that the idea of efficiency within a healthcare system needs to expand its concept to build in a redundancy. A redundancy of 20% or so is actually essential so that when there is a crisis, that can be met. And that requires sustained public investment in primary healthcare. And that will be required for many years, as the Nicaraguan case shows, in fact. And what that means, of course, is that preparing for pandemics, in fact, involves general health resilience, the healthcare resilience of a system, which means that it will be able to deal both with a new outbreak of an infectious disease, as well as, of course, the many existing healthcare needs which populations have. That framework of preparedness also involves social protection. One example we looked at was Cambodia, where a large-scale social protection system built in advance meant that it could be expanded during the pandemic, so that even though it had only just become a middle-income country, it was able to provide, for instance, furlough. Nicaragua is also a good example of this, in fact, expanding the free school meals that children get at school to 2 meals a day during the pandemic so there would not be nutrition issues. All this shows, again, the requirement for built-in social protection and public investment in that to develop for many years in order for it to be able to cope with crises. All of this also involves an understanding of risk, a contextualization of risk and its disaggregation. People around the world have many different priorities. They don't all face the same risks, and the same disease may have many have a big differential in terms of outcomes for people, demographic differences, population density, housing and climate differences. All of these mean that a new infectious disease such as COVID is not the same priority for people in different situations around the world. Fundamentally, this requires understanding that there are different priorities and different perceptions of risk in different communities around the world, that these vary hugely, that they are contextual. And that the people who have the best understanding of this are the individuals and the communities who are involved in those risks. And they must therefore be involved in shaping new plans for health crises and in implementing them. And that requires both community engagement, a sort of a decentralization, but also the enablement and empowerment of communities to make those decisions through sustained national government investment.